as you're looking at your impact cases, yes, it's important to handle the acute issue. However, we need to look back and say, okay, what caused that problem? And this is something that we're going to see over and over again. It's a common phenomenon in the ICU. And seizures are a very common part of it, if you really think about it. But you have to explain why. See, if somebody had a seizure or a status epilepticus in the ICU, the question that has to be answered is what happened and why. If the patient had, let's say, traumatic brain injury, and they were being covered by anti-seizure medications, then okay, that should have prevented the seizure activity. If it didn't, then the real question is why? Okay, what happened and what are we dealing with? Okay, so the issues here we're going to be talking about this morning are about status epilepticus, which is continuous seizures in the ICU. Remember, status epilepticus is a medical emergency, really speaking, and we have to think along the lines of how we want to deal with it. Okay, so let's start. Mani, next slide, please. Okay, so originally we used to define status epilepticus as seizures that lasted longer than 30 minutes or 30 minutes of recurrent seizures without getting back to normal neurologic status. Now, the operational definition now has come to 5-minute duration of continuous seizure activity or 2 or more seizures between which there is no complete recovery. So if you're looking at a patient, the patient started seizing, okay, and the seizure is continuing, we're finding that you get more brain damage if you wait to treat. And again, timeliness of intervention is everything here. So as you guys are recognizing issue, you have to push the intervention very aggressively. And here's the thing, as you're looking at how to manage this patient, keep pushing the bedside team to keep working with you on this, because they need to be administering the pharmacologics and so forth, and we have to give the appropriate supportive care. Otherwise, the patient will incur significant brain damage. And remember, this is a seizure is like a massive discharge of nerve activity in the brain. So it's sucking up a lot of glucose, lot of energetics, and generating a lot of heat and causing all kinds of problems for the brain. So understand that and don't take it lightly, especially even if the patient has a history of seizures. Don't take it lightly. Watch the patient closely and go through what we're going to go through at this stage. Next slide. Okay, usually we divide it into 2 types, right? We have convulsive seizures. Convulsive seizures is where you can see the patient moving. Now, the caveat I'll put for that is if you've paralyzed the patient, remember, they can seize under the paralytic. This is why with TBI patients, we warn people not to really paralyze unless you absolutely positively need to, because they can seize underneath the paralytic. So they may be seizing, you may not see it. So that's something to keep in mind. Now, oftentimes they don't start off, the seizure doesn't start off as a generalized seizure. What it does, it starts off as a localized seizure, and then it starts expanding out to a full generalized seizure. Now, if you're watching carefully, you can pick up on this. Now, convulsive seizures are usually the most common. And they can be due to many things, and we'll talk about the different things that can cause it. But as you're thinking about managing the seizure, I also want you to be thinking in your mind about what is causing the problem, background, and can this causing agent continue to be a problem for us going forward. And remember, as the patient continues to seize, the risk of incurring permanent brain damage is there. So you have to be thoughtful about that. Now, here's the other scary thing about patients in the ICU. We have something called non-convulsive seizures. Now, non-convulsive seizures is where the patient is less responsive than before. And this is why it's so important for our nursing to be actively involved in the helping the management of our patients. Because if you notice that the patient's mental status is altered and you don't have a reason for it, okay, you're not sure what's going on. One of the major issues that need to be recognized is non-convulsive seizure activity. So if you're seeing non-convulsive seizures, you need to think about getting an EEG, electroencephalogram, done at the earliest possible interval. I understand that some of our ICUs, we don't have that capacity. I understand that. But keep that in the back of your mind. And also, you can use anticonvulsive agents empirically in that setting to think about the possibility that this might be NCSE, and if it is, an anticonvulsive agent empirically started may be beneficial in this setting. So we'll talk about that as well. Next slide. Okay, now when we talk about convulsive seizures, now you're going to see patients that are twitching or doing something, and it may not be a seizure, because you need to check whether the mental status of the patient is still there or not. If the mental status is still there, that's just myoclonus. That's not a seizure, okay? If the mental status is not there, if they don't respond, then it's a convulsive seizure, and you're going to have to think about that. So each of these patients need to be thoroughly evaluated, okay? Good history and physical examination is extremely important. And I want you guys to really think about it. And again, as you're working with the bedside team, the emphasis is that you have to, get the bedside team to get that index of suspicion that this may be seizure activity. If this is seizure activity, then we need to address it more aggressively, and we have to think about what we're doing. And again, your corneal and pupillary reflexes usually are lost. The plantar reflexes may be downward going, like the Babinski sign, if you will, right? So these are things that you can expect to see, and you can clinically, you don't need to have an MRI or even an EEG at this juncture. If you look at the patient clinically, you can make a diagnosis. And once you've made a diagnosis, turn your stopwatch on, because if you put on your stopwatch, okay, look at your timing. How many minutes have gone by? You'd be amazed at how fast the clock moves. And you have to really be careful here and be aggressive about getting those seizures stopped. Next slide. Now, again, you'll get motor manifestations that start as a focal twitching, and you may get eye deviation. We'll show you some of these things. Now, they may present in a more subtle form. And again, patients who have encephalopathy, patients who have other things going on, they may not present as overtly. So have an index of suspicion. Now, if the patient's mental status has changed, and again, I'm noticing that you guys do document GCS very nicely, but if the mental status is changing, you're going to have to understand why. what is going on. And you may, if you want to get an EEG, fine, get the neurologist involved, get them if you can. Now, if you don't have a neurologist available or EEG available, then fine. In that setting, what you need to do is do your clinical evaluation, start your therapeutic medication or empiric medication, and protect the patient's brain. So again, think about how you're going to do that. And we're going to talk you through this. Next slide. Now, this is an eye deviation. Now, if you notice these kind of things and the bedside team documents these kind of things, then what we need to do is we need to ask the question, what's going on? Okay, next slide. And this is an electroencephalogram. This is how the leads are put on the brain, on the skull, and then we look at the electrical activity within the brain. Now, obviously, to an untrained eye, this looks like gibberish. Very true. However, to a neurologist, they can tell you this is seizure activity, this is not seizure activity. They can tell you this, but you need to get a neurologist involved. Get your team moving. Now, in the meantime, you're going to start empiric therapy. Now, that will still, it may still not be fully effective against the seizure activity. So you'll be able to tell, even if the medication is started, you'll be able to tell what's going on. Next slide. Okay. In adults, okay, mostly the myoclonic syndromes are usually secondary to toxic or metabolic encephalopathy, which means you can get by history, you can know what's going on, okay? By getting a good history and a physical examination, you can make the diagnosis right off the bat, okay? Again, you don't necessarily need an EEG. You know, EEG is nice, it's a confirmatory test, but it is not necessarily a needed test. You can get to your diagnosis clinically, and it's important that we do that. Next slide. Now, you can have partial seizures, and that is, again, this is the second most common portion. It can be localized to a face or an extremity, and then it can spread over time. Now, this is something that you have to keep an eye out for. That means the bedside team has to be aware, and you have to tell the bedside team, keep watching for this. If you notice the first signs of seizure activity, get the bedside team on it and keep telling them and reminding them what they're looking for, because they may not be aware. So again, it is our responsibility at the care center that we guide the bedside team in these subtle findings. And again, it's very important. Hyperglycemia, metabolic disorders can cause these kind of things. And you have to watch for this. Now, I notice a lot of times we have altered mental status in our patient, and we have a patient, let's say, in diabetic ketoacidosis or a hyperosmolar non-ketotic state. Now, you're looking at that patient, you're thinking, okay, this is going to resolve. But if the patient seizes, then you have to say, okay, is this being caused by this problem? And how are we going to fix it? Next slide. And again, non-convulsive SE. Think about seizure activity. Think about this as a seizure activity that is not motor response, but think about it that way. You'll find that we miss a ton of seizure activity that you would think, oh, this is not seizures, but it is. And when we start the anti-seizure medication, the moment we start the anti-seizure medication, the mental status improves. And then you go, hey, this might have been a seizure. You know, and that's how you have to think about it. You know, as you're looking at your patient, I really want you guys to be thoughtful about what's going on mental status wise, what's going on with the patient, and explain why. Don't just leave it. The mental status been that way. No, don't leave it. Come back and ask the question, what triggered it? What is the problem that triggered it? And if it is, let's say you think it is sepsis, mental status is altered because of sepsis. Well, you started antibiotics, you started your sepsis protocol, and yet after 24 hours or 48 hours, you haven't noticed an improvement in mental status. If you have not, think of seizure activity. Think about this as a possible seizure issue, and think about starting anti-seizure medication prophylactically, if you will call it. You can call it empiric or prophylactic, but start it. See how the patient does. I wouldn't call it prophylactic, I would call it empiric. Next slide. Okay, and again, absent seizures, you can have a variable level of altered consciousness. Okay, you may have subtle myoclonic movements, eye blinking. This we see in trauma patients all the time. Okay, we see this kind of thing, and originally my staff used to blow it off. And I would come and see the patient, and I would look at that, and I would say, hey, what's that? And they would say, well, that patient's been doing that for the last few hours. And then I'd say, hey, that's seizures. Let's go back and evaluate, and let's treat the seizure activity. And sure enough, the patient does better. So again, please understand that an index of suspicion is extremely important. When you're looking at these patients, have a high index of suspicion, especially if you're dealing with neuro patients, on a regular basis. This is something that comes up commonly. If you're dealing with TBI patients, comes up commonly. This is not something that is unusual. This is not something that is rare. It is very common. Next slide. Now, again, what causes seizures in this setting? Okay, what causes status epilepticus? Brain trauma, brain tumors, strokes, hemorrhages. Now think about how many times we see this in a daily basis. We see this all the time. Now, CNS infections like an encephalitis, like a meningitis can also cause. So sepsis issues that come up, you should be thinking about it. Drugs, okay, lidocaine, penicillin, withdrawal states, alcohol, etc. You can see how this fits in. So when you're looking at such a patient, I want you to think in the back of your mind, is this seizure activity? And if it is, okay, can I just empirically start something? Yes, and we'll talk about what to start, and also how to work it up and figure out whether this is indeed seizure activity or not. So again, something to think about, okay? And the other thing I want you to keep in mind, if the patient does have a history of seizures, now think about this clinically. If someone is going along normal, all of a sudden they start having more seizures. You have to ask the question, what triggered the problem? Oh, but they have a history of seizures, sir. No. It's like COPD, right? A COPD patient is going along normal, okay? They're on their medications, they're continuing to use their medications, all that is going on. Yet, all of a sudden they decompensate. The question is why? Why did they decompensate? Yes, they decompensated. Yes, you're treating the decompensation. Yes, they seized. You're treating the seizure activity. But why is a question that has to come up. Is there sepsis? Was there an error in the medication that we gave the patient? Was there an error in the medication that was being taken by the patient themselves? Was there a change in the anticonvulsant level? Remember, anticonvulsants, as far as drug interactions go, are one of the highest issues as far as that is concerned. Anticoagulants and anticonvulsants interact with each other. See, when you're giving, let's say, an anticoagulant along with an anticonvulsant, you can alter the levels of anticonvulsants. So you have to be careful. Or let's say they drink alcohol. If they're drinking alcohol, their effectiveness of their anticonvulsant may go down because this P450 enzyme may be more active in the patient that drinks more alcohol. So you have to think about these things. Next slide. So again, mortality. I'm not talking about morbidity. I'm not just talking about a little bit of brain damage. I'm talking about death. Okay, depends on etiology, what caused it, how long did the seizure continue? And this is important. Our documentation has to be precise. Once you start seeing seizure activity, the documentation of how long the patient has been seizing. So if you have a stopwatch in your phone, start the stopwatch and see how long the seizure activity is going on. Document it. How old is the patient? This is something that's pretty obvious. We'll talk about that. Once you get over age 70, it becomes very problematic. So you have to think about that. We're going to talk about each of these things. Now, if you look at acute insult, what we see a lot of in the ICU is one of the most important factors that influences mortality as far as patients with seizures in the ICU go. So you have to think aggressively about what's going on. Remember also, if patients seizing, they're going to have a significant metabolic acidosis, right? Now, what will also happen is that metabolic acidosis will correct very rapidly once the seizure activity is stopped. Okay, so if you're getting a blood gas immediately after a seizure, you may notice a huge amount of metabolic activity there. You may notice a huge metabolic acidosis, a lactic acidosis that's enormous. But within another 5 minutes, if you repeat the blood gas, you'll notice that the metabolic acidosis is corrected. And you know that that's an issue. Okay, so that's something going on. But again, if you have hemorrhage, if you have tumor, if you have metabolic disorder, systemic infection, that's the highest mortality rate if you see seizure activity during that time. If you have a patient that you think has, not taking enough medication or alcohol withdrawal, or you're not sure what's causing the issue, idiopathic, you've done your workup, you're not sure, the mortality risk is actually lower. So do your workup. It's very important. Do your workup. Don't just let it go. Okay, next slide. Okay, again, duration of seizure activity. Remember, if your status epilepticus lasts more than 60 minutes, seizure duration lasts more than 60 minutes, mortality rate is up to 32% minimum. Mortality. Okay, about a third of these patients will die. Now, compared to if you can control the seizure activity within 60 minutes, notice 2.7%. I agree, this is like 1 or 2 studies, but it's giving you an example of duration having an impact on mortality. If you have an older patient, act quicker. Don't wait. Okay? Patients have age over 70. Oh, but he looks like a 60-year-old. No. Their age is what their age is. Please remember that. Okay? And convulsive seizures have an overall mortality can range up to 1/4 of your patients can die. So you really have to look at these patients closely and carefully. And even when you control the seizure activity, you have to get an answer as to what triggered the problem. Don't let it go. Get an answer. Figure out what is causing the problem so that it doesn't happen again. That is called source control. We talk about source control all the time, right? But source control is where if you have something triggering something, you got to get it under control. If you don't get it under control, you got lucky this time. You caught your patient. You controlled the seizure. But next time you may not be so lucky and the patient may die. So be careful and watch. Always be watchful. Watch. Okay? And other adverse outcomes like intellectual deterioration, permanent neurologic deficits, chronic epilepsy may occur. So keep an eye out. Watch the patient closely and make sure that the patient and the family are also educated on what's going on. Don't just leave it. Oh, the patient had a seizure, we fixed it. No, 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 no. We're working it up to figure out what caused the problem. And once we figure out what caused the problem, we may have additional solutions that may need to be implemented for this patient. Don't let it go. Next slide. Okay. What are other systemic complications? Remember, seizure activity is not just about the seizure. You can have secondary metabolic and medical complications. You can have tachycardia, hypertension, and what the result of that can be arrhythmias. You can have all kinds of issues coming up. This is why we are so careful in our head injured patients. We're so careful about watching for seizure activity. Now, here's the other thing. Remember, in TBI patients, long-term putting on anti-seizure medication is not necessary. However, short-term is absolutely necessary. Why? Because if they have seizure activity and it's not terminated properly, then you're going to have an issue going on later. You're going to have more dysrhythmias. You're going to have more issues. Look at the respiratory issues. You can have tachypnea, okay? You can have apnea, where the brain center, the medulla oblongata, does not work properly, and you cannot breathe appropriately. Your autonomic dysfunction is there. You can have bronchial constriction. That's why in these patients, you have to listen, have the bedside team listen to the lungs. Make sure you're not getting wheezing. Make sure you're not getting bronchial constriction. Make sure that these patients are on bronchodilators. Are they developing neurogenic pulmonary edema? Do you hear creps at the bases? Now, here's the other big thing. I see people listening from the front, and if you notice on your camera, the doctor and the nurse will listen from the front, but they won't listen from the side or the back. Now, when you're listening to the lungs, here's the thing. Which part of the lung does most of the work? The lower lobe. And because it's the lower lobe, can you hear the lower lobe from the front? Well, the answer is obviously no. Okay? You cannot hear the lower lobe from the front. You have to listen from the side or the back. If you're only listening from the front, you're not going to know. So this is where we have to intervene and tell the bedside team. The bedside nursing has to be educated. Same with the bedside RMOs have to be reminded. You can do it nicely, politely, obligingly, but you don't have to oblige. So make sure that you're guiding properly. The patient may have autonomic issues, dilated pupils. Okay, you may have salivary or tracheobronchial hypersecretion, lots of secretions. The patient may need to be intubated related to that. So keep an eye out. Okay, you may see diaphoresis. Now, if you see excessive sweating, here's the other problem. Ladies and gentlemen, you have IVs that these patients have. Most of them have peripheral IVs. And if a patient is sweating, what happens to that peripheral IV? Oh, sir, it fell out. Why? Because the adhesive that's holding the IV in place got sweated out. Keep an eye out. Watch. Have the nurses bedside nurses pay close attention to keeping that peripheral IV secure. Make sure that you're watching. You're the eye in the sky for the care team. And for the bedside team, you are the spear, the tip of the spear. Please understand that. Okay. So again, when we're talking about acidosis, you can have lactic acidosis, you can have hyperglycemia, you can have hyperkalemia. These are all systemic complications related to seizures. Keep an eye out. Next slide. Okay, so what do we do? First and foremost, I want you guys to remember, this is a medical emergency. Don't just say, oh, the patient is seizing. We're in the process of getting the medication for the patient. No, no, no. Get aggressive. Get on the bedside team so that the medication can be in. It's not having the order put in. It is when the drug hits the patient's veins and the system. Okay? Pharmacological intervention is more effective earlier in the seizure activity than after a delay. This is a very important concept. If I can get the medication into the patient within the first 2 minutes, as opposed to the first 10 minutes, the effectiveness will be better. So it's very important. So fourfold treatment. First, terminate the seizure. Get the seizure to stop. Okay? And some people actually, younger medical students have asked me in the past, hey, sir, if we paralyze the patient, won't that make the seizure go away? No, it does not. It just makes it so that you can't see the seizure anymore. It's like sticking your head in the sand and not seeing anything. Yes, I don't see it. So every time you have a patient, this is why we aggressively tell people don't paralyze unless it's absolutely positively necessary. And even then, short-term paralysis only, even for ventilated patients. Think about that. Now we want to prevent recurrent seizures. We'll talk about that as well. Identify etiology. What caused the problem? This is very important. Because if you don't identify it, yes, you caught the patient this time, but next time you may not be able to catch the patient and the patient will arrest and die. So the urgency of finding the etiology is extremely important. Then also you're going to treat any complications. Keep an eye out for the complications. Next slide. This is why attention to detail is so important in the ICU. I emphasize this on all areas, but attention to detail saves lives. Please remember that. Now, we have lots of protocols, and this is going to be one of the protocols for management of seizure activity, right? Status epilepticus. However, what I want you to do is put in the application. Now, we have a sepsis protocol. Yet, when we see sepsis, I would say probably only maybe 70–80% of the time we're implementing the sepsis protocol fully. And we have to implement. The protocols are there. Please use them. And my admonition to everyone is, if you see something, say something. If you're seeing a seizure, say something. Oh, someone else may have noticed it. No, they may not have. Someone else may have noticed a partial focal seizure. No, they may not have. So it's just like, in the airport, if you see a package or see something suspicious, see something, say something. Same rule in our ICUs. If you see something, say. If something catches your eye, and we talk about our eagle eyes all the time. If you guys catch something, look closely, and again, it's very important that once you see something, make a note, tell somebody, tell the bedside team to follow. Now, NCSE, remember, may present as only a change in mental status. And if that's the case, as you're watching or the bedside team is watching, by saying, sir, yesterday this patient was talking about his grandkids and his kids and all that, and today he's completely silent. And I go over and I see the patient and the mental status has changed. Now, in addition to getting my CT scan, all that I'm going to get, but I'm also thinking about seizure activity. And that's how you make the diagnosis, because you have to think ahead. So very important, okay? Once a diagnosis of seizure activity is made, treatment must be started. Don't wait for final confirmation. Don't worry about reaffirmation using EEG. Don't wait for that. Treat the patient. Remember, time saved is brain saved, just like the heart. If you move quickly, you'll save brain. Now, here's the other thing that you have to remember. Now, when neurons start getting damaged, what leaks out into the extraneuronal space? Calcium. Now, here's the thing. The patient may develop alteration of mental status because their blood vessels are spasming in the brain. This is one thing that is different than other parts of the body. When you reperfuse other parts of the body, it's not an issue. They do a little bit of swelling, but it's not bad. But the brain, the blood vessels will spasm. So you really have to watch for that. And you may need to use a calcium channel blocker like nimodipine or nicardipine to correct that. Now, fortunately, these patients will also develop systolic hypertension. So you'll see. So think about that. Okay. So again, the treatment, initial assessment and treatment should begin within 5 minutes. I'm not talking about an hour. I'm talking about 5 minutes. In fact, 5 to 10 minutes is being liberal. 5 minutes. Okay. So you have to start. Next slide. Okay. 0 to 9 minutes. If the diagnosis is uncertain, you're not sure. Okay. Watch for recurrent seizure activity. If you're seeing recurrent seizure activity, congratulations. Establish your airway. Put the pulse oximeter on. If the patient is not getting supplemental oxygen, get them on supplemental oxygen. But sir, their saturation is okay. Put the supplemental oxygen on. Put the cardiac monitors. Now the leads are not, the patient is fatty, sir, the leads are not sticking. Get the leads to stick. Dry off the patient, get the leads to stick. Establish your IV access. Make sure that peripheral IV is secure. Do a rapid bedside glucose determination. The probability that a seizure was caused by low glucose is pretty low, but it's a very easily correctable problem. So because of that, you want to just quickly check. It doesn't take very long. Okay. Just have them quickly check. Now, you're going to send off labs. Now, you're going to send off labs indicated by, looking at CBC, looking at electrolytes, BUN, creatinine, glucose, anticonvulsant drug levels, tox screen, etc., 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 depending on your history and physical examination. You've done a good history and physical examination, you'll know what to get. Okay, 5 to 30 minutes, you're going to start your therapy. 5 minutes, you're going to start your therapy. Lorazepam. Okay. And the reason we use lorazepam as opposed to diazepam, it has a longer duration of activity. Diazepam is actually very good, but we don't give diazepam IV. We give it sub-Q, rectal. IV diazepam can cause some issues, some reactions and stuff. But IV lorazepam is actually very good. Okay, so lorazepam is something that we use on a regular basis, or any benzodiazepine if you have it. If you don't have lorazepam, if you have midazolam, use it. Now, if you have phenytoin, load the patient, 20 mg per kg. Load them. Now, once you load them, now if you have phospheniton, you don't have phenytoin, fine, use the equivalent. Okay, calculate the equivalent, use the equivalent. Okay, Or if you have levetiracetam nearby, use levetiracetam. Whatever you have, get it on board. Levetiracetam is good because I don't need to check levels. Now, phenytoin, because I'm just bolusing, I'm just giving the loading dose, I don't have to worry. Don't worry about toxicity because first dose is always free. Remember that. Now, I'm not talking about cost. I'm talking about physiologic consequence. So whenever you're giving the first dose of any medication, you don't have to worry about toxicity issue. I mean, there is acute toxicity stuff that happens, but that's frequent. Most toxicity is over time, right? So I don't have to worry. I can give that first dose, control that seizure activity, right? Do your cardiac monitoring, check your pulse ox, carefully watch how the patient is breathing. Now, here's the other thing I'm noticing is being dismissed. Patient is breathing awkwardly. When you're looking at a patient and they're not breathing right, they're kind of breathing, respiratory rate is in the 20s, but they're breathing awkwardly. Say it. If you see it, say it. Document it. Say that the patient is breathing awkward. You don't need a diagnosis. You need to put the data out there so people can see it. If you see something, say something. Very important. Now, if you can do EEG monitoring, get it on board. Now, the other option that you do have that most people don't think about in the ICU is if you have an operation theater in that hospital, they have something called bispectral analysis, BIS monitoring. And BIS monitoring is the same technology as EEG. So they can tell whether there is seizure activity going on or not and how depressed the functionality of the brain is by putting a BIS monitor on. You can do that. That's a, how do you put it? It's a poor man's EEG. But you can use it. Okay? Repeated dosing of lorazepam or phenytoin or levetiracetam may be needed. Do it. Remember, 31 to 60 minutes. If the seizure activity is still persisting by a half hour, you're on the clock. Get phenobarbital on board. Now, if you're going to put phenobarbital on board, remember, they're going to stop breathing. So you're going to have to intubate the patient. Get ready. Get the bedside team to prepare. Have the airway roll ready to go. Have the laryngoscope, have everything ready to go. Get the RMO notified. Get the anesthetist notified. So all these things need to be moved on. Okay? And then consider intubation for respiratory depression. If the patient is slowing down their breathing, don't wait for the patient to become apneic. If they're going from 25 to 10 to 5, don't wait for them to stop breathing. Bag them, put NIV, bag them, get them intubated. Now, the NIV won't help for very long, but at least it'll buy you some time while you're trying to get the intubation stuff ready. And if you're on neuromuscular blockade, then you need EEG monitoring. You cannot go on neuromuscular blockade unless you have EEG monitoring, because you're going to, the patient may be seizing underneath and you won't know. Next slide. Now, if it's more than 1 hour, think about inducing coma. Use pentobarbital. Get some either midazolam drip or propofol drip on board. Control the patient. Get the patient's seizure activity stopped. You should be at 0 to 9 minutes, you should be yelling. 9 to 30 minutes, you should be yelling louder. 30 minutes to 60 minutes, you should be screaming. After an hour, you should be yelling so loud that no one else can hear except you. Whatever you're saying should be heard. Be emphatic. Don't be rude. Be emphatic. There's a difference. Next slide. Okay. Now, remember, Get the history within the first few minutes. Sir, we don't have a history. Get it. Talk to the family, have someone talk to the family, have someone talk to anybody, their family medicine doctor, find out that information. Were they on, did they have fits before? Are they on an anti-epileptic drug? Are they drinking? Are going on? Any recent neurological insult? Do they have a systemic illness? Do they have hepatic disease? Do they have an infection? Do they have uremia? Are they on cocaine or other drugs, fentanyl? Remember, these drugs are readily available in the street. Don't think otherwise. Oh, this is India, sir. They're not readily available. Of course they are. In fact, the more affluent, the more likely. The more money they have, the more likely. So think about that. Is there evidence of trauma? Is there focal neurologic abnormalities? Did they notice something? Now, if you're administering glucose, give timing. Make sure that they're giving timing. Don't forget, Wernicke-Korsakoff can happen. So think about that. So give timing. It's nothing, just a banana bag. We call it a banana bag in the US. B12, timing, folate, all go in one bag and just run it. You give one banana bag, you're all set. Okay? The reason it's called a banana bag is because it's yellow in color. The B12 causes a yellow in color. But again, if you need a banana bag, give a banana bag. Next slide. Now you notice we can use diazepam, lorazepam, phenytoin, phenobarbital. These are the original things, but look at the side effects. You can get respiratory depression. You can get apnea. It may be abrupt with diazepam. With lorazepam, it is less, but you can still see it. The issue here is you have to watch for the side effects. Be careful. Think about what's going on and the duration of effect. Remember, diazepam doesn't last as long. It's quicker to act, but the drug of choice, really speaking, is lorazepam. If you have it, use it. If you don't have it, use midazolam or propofol, whatever you have. But if you have it, use it. Next slide. Now, if you're seeing absent seizure activity, the ideal drug is valproic acid. But again, think about what you have. Think about how you can manage. Again, go through the steps. Next slide. Here's what we have to learn. One, seizures are a true medical emergency, especially status. If they seize for more than 5 minutes, needs to be treated promptly and definitively. Don't wait. Lorazepam is the drug of choice. Why? Because it lasts longer. It takes effect within a couple of minutes. It doesn't take effect as quickly as diazepam, no question. But it takes effect quickly enough, and it will terminate the seizure activity aggressively. That's good. Phenytoin needs to be given simultaneously. Load it. Give it. Phenytoin is safe and effective early. Give it early. If you need to give it for later therapy, fine. I don't care. That's later. Oh, we need to check levels, sir. Okay, fine. Do what you got to do. But you've controlled the seizure activity now. If these drugs are ineffective, think about the barbiturates. Use barbiturates as you need. But if you're going to use barbiturates, remember, the patient won't be breathing. So you have to take over breathing for them. Keep that in mind. All these things, as you're going through, keep an eye out. This is what we mean by eagle eye. You're not just observing. Say something, tell, do tell. Also, once you are there and you know that there's a problem, start raising alarms. Raise as many alarms as you can, because this is a medical emergency. This is not something that we're just going to sit on. It needs to be aggressively treated. Then we need to figure out what caused it. Okay, I'm sure questions will arise as you're seeing patients. Please bring them forward. Ask people. talk to people. The beauty of Cloudphysician is we have the platform to have these discussions. Use the platform. The platform is wonderful. Radar is wonderful. Use it. If you don't use it, you're not gaining the benefit of the knowledge of all these people that are around you. Use the platform to discuss. Get answers. Think about what's going on. And if you're not sure, ask. You'll get clarification. We have enough very brilliant people that can give answers. So please ask. Okay, especially nursing staff, nursing at the care center, you guys are the tip of the spear as far as we are concerned. And the bedside team is the tip of the spear as far as the patient is concerned. So work together and keep moving forward. Don't just think nursing, think medical. You guys are physician extenders. Always think that way. The more you think that way, the better it'll be. Okay. Have a good day. We'll talk more later.
Thank you, Akella. That was good.
Okay.
Thank you, sir.
Very good. Okay.